So he had an episode of a urine infection at 2 weeks of age, and following that he was investigated and he was found to have posterior urethral valves which were ablated, and he has chronic kidney disease. You can see his observations: heart rate 150, blood pressure 90 systolic, respiratory rate of 35, and he has a temperature of 37. He has dry mucous membranes, but warm peripheries, well perfused, and he passes urine well. You can see a full nappy while you examine. He has no peripheral edema, and his weight is 15 kilos. So what is your first impression? This is a quite common presentation, I would say, in A&E. Is this boy dehydrated? And what else would you like to know? Yes. Yes, I agree. He is mildly dehydrated, and you can tell that from the mild mucous membranes, isn't it? And he does have a little bit of tachycardia as well, I agree. But he's warm, well perfused, so I agree it's mild dehydration. What else would you like to know? Is there anything else you might want to know, or any investigations you might want to do? I'll put the case up. I think it's more helpful to look at everything again. Yeah, certainly, I agree with all of you. So we did a urine dip. We have to be very careful with UTIs. This child had a background of UTI, so that's the first thing that needs to be excluded. So urine dip was all negative. And these are his blood tests. So anything you're worried about from the blood tests? Or anything else you might want to know? Yes, creatinine is 60. This is an abnormal creatinine. We already know that this child has chronic kidney disease. So someone asked what the weight was before, and we did have a weight from a clinic letter. So it was 15.82 months before. So that was 800 grams down. This is actually a 5% weight loss. Normally, mother says he has 10 wet nappies a day, and his baseline creatinine, quite important thing to look in the previous clinic letters, ask his team, is baseline creatinine. So it was 50 and it's gone up to 60. So that's not too much higher, but it's definitely higher. So we need to do something about it. So given that the urine dip was negative and he didn't have any other focus of infection, his CRP was not high, his diagnosis was viral gastroenteritis. He was admitted to receive IV fluids, and which was for almost 24 hours, and then this was changed to oral fluids as he was tolerating oral fluids. And then he had repeat Usenis to ensure that the creatinine was back to baseline. Someone said potassium was high. Let me remember what it was. So potassium was 4. Yeah, so that's, I would say that's normal. So I wouldn't worry too much. He's passing urine well. So 4 is okay, and we will see what it is on repeat Usenis. So a little bit on assessment of fluid status in pediatric patients. I'm pretty sure most of you have seen this before. These are the NICE guidelines on management of children who present with diarrhea, vomiting, dehydration. And every single thing on this table is quite important when we assess fluid status in kids, we should check at all these things. A child who appears well, is alert, responsive, has normal urine output, his skin color looks normal, his eyes are not sunken, his fontanelle, their fontanelle is flat, they have moist-induced membranes, their observations are okay. This child is not clinically dehydrated. We do have to take into account the history though. So even if a child does not look dehydrated, a history of 10 episodes of vomiting or diarrhea in 24 hours is quite significant, so we should keep that in mind. I would like to also just stay a little bit on the warm extremities or cold extremities. I think that you don't necessarily need to have a child who is shocked in front of you to have cold extremities. In pediatric nephrology, we are quite thorough when we examine kids, and we feel the feet, the hands, even the nose, and we take this into account, of course, in the context of everything else. So back to our patient, how much fluid are we going to give over 24 hours? What do you think? So A is maintenance, B maintenance plus 5% deficit and replacement of ongoing losses, maintenance plus 5%, or are we going to give a fluid bolus of 20 ml per kilo and then start maintenance fluids? Yeah, I agree with you. Maintenance plus 5% deficit and replacement of ongoing GI losses. Now, how are you going to do that? Are you going to start from the beginning, calculating 10 episodes of diarrhea in 24 hours, or are you going to keep reassessing every few hours and see how many episodes of diarrhea and then replace? There's no right or wrong way to do that, as long as you keep reassessing your patient and doing your fluid balance. But how much is maintenance going to be? We said this is 16 kilo child. How would you calculate the maintenance? How much fluid would you give for maintenance over 24 hours? So the usual calculation we do for a 16 kilo child would be for the first 10 kilos to give 100 ml per kilo, and for the next 10 kilos, from 10 to 20 kilos, to give 50 ml per kilo over 24 hours. So that would be exactly, so 1.3 liters. But I agree with you. Sometimes we have to be a little bit more careful with patients who have a background of kidney disease. So remember, this mom said that her child has at least 10 wet nappies a day. It's not unusual to see patients with posterior urethral valves to be polyuric, and therefore they have polydipsia as well. It's not unusual to, on further questioning, to hear a story that my child sleeps with a bottle next to them and drinks overnight. So mother tells you that child usually drinks 2 liters per day. This is going to be your maintenance. Now again, would you prescribe that from the beginning? I would. Or would you want to start with 1.3 liters per 24 hours plus the deficit and the ongoing losses and keep reassessing? But this is a child with chronic kidney disease. Creatinine is already slightly raised. You don't want to add any injury to the kidney. You want the kidney to be well perfused. You want to rehydrate your patient. So you don't want them to be in negative fluid balance. So your aim would be to have a neutral or slightly positive fluid balance, at least for the first few hours. Now, 3 years later, And the same child presents again. You were the F1, now you are the pediatric SHO. You remember the boy because you had learned a lot of things from that case. So he presents at 5 years of age and he's now on CKD stage 4. So yeah, he's had a couple of episodes of acute and chronic kidney disease, and his disease gradually developed. So he is in stage 4, secondary to posterior urethral valves. His baseline creatinine, you know to ask now, is 120, and his polyuric, mother tells you. He has, and this time the presenting complaint is 2 days history of fever and a sore throat. You can see his observations. So the only finding on clinical examination is red inflamed tonsils. So your diagnosis is tonsillitis, and you think this child needs to be started on amoxicillin. Is this child dehydrated? And what else would you like to know? And I will go back so that you can see the OBS and clinical findings. I kind of have to assume that someone is typing and wait, sorry if no one is. Yes, I don't think he is dehydrated. He might struggle to drink as well, yes. From your clinical assessment, there are no signs of dehydration. Yes, I would do a urine dip again. I agree with you. So you'll have to take a bit more history. Mother says that, oh yes, he's not drinking very well because he has a sore throat. She even had to give a little bit of ibuprofen at home that she normally doesn't give because the throat was quite inflamed and painful. So these are his bloods. Urine dip this time shows 1+ of protein and 1+ of leukocytes. I think this is unlikely to be a UTI, given you have a very clear focus, but you would probably still send your sample for MCNS. Yeah, ibuprofen should not be given. What do you think about his bloods? Is there anything you are worried about? Hyperkalemia, yes, potassium is 5. I would say it's still at a safe level, but we definitely need to keep a very close eye on it. So if I would get called with this case, I would have said to repeat Usenis in 12 hours latest, probably. His creatinine is very high. Creatinine is doubled. So this is an episode of AKI, of acute on chronic kidney impairment. It was 120 the baseline, and it's now 240. It has doubled. Another I think I always look at the blood tests when I have to assess fluid balance is the hemoglobin to see how hemoconcentrated your child might be. It's difficult if you don't know the previous hemoglobin though, unless it's a very high result. So this is a child with acute and chronic kidney impairment, and he needs to be admitted for close monitoring. So I think it's probably multifactorial, this episode. So he was probably a bit dry, but maybe ibuprofen contributed as well. So a little bit about chronic kidney disease. Chronic kidney disease is defined as abnormalities of the kidney structure or function that's present for at least 3 months and has implications for health. This is the definition of KDIGO. KDIGO is a global non-profit organization that produces evidence-based guidelines for kidney disease. And we say that we have chronic kidney disease when the GFR, the glomerular filtration rate, is less than 60 or more than 60 with evidence of renal structural damage. CACUT, that's congenital anomalies of kidney and urinary tract, is the commonest cause. And then so posterior urethral valves is in this category, and glomerular disease gets commoner with increasing age, but a lot of other causes of chronic kidney disease as well, so nephrotic syndrome, nephronophthisis, stones, systemic disease like SLE, for example, vascular events, and AKI episodes can also lead to chronic kidney disease. The true incidence of CKD is not really known because it depends on the region, on the resources, quite often remains undiagnosed. But the number is 2 to 16 cases per million of childhood population per year. This number in the UK is around 10. It's associated with decrease in life expectancy, and the mortality risk increases with the severity of chronic kidney disease. So patients who will end up on dialysis, renal replacement therapy, they have reduction in their lifespan of around 50 years. And for transplant, for patients who receive transplant, that would be a reduction in the lifespan of around 20 to 30 years. Progressive decline in renal function does not happen if only one kidney is affected. And in the first 4 years of life, sometimes improvement can also occur. And children with glomerular disease, with proteinuria, hypertension, are more likely to have a progressive decline of kidney function. So these are our aims, managing these children to control any proteinuria, for example, or hypertension. And this is how chronic kidney disease is, I will say, classified. So it depends on the GFR, the glomerular filtration rate. So according to the GFR here, then you have these stages of CKD. And then, as you can see, these colors getting red, it means that these patients are more in high risk for progression if the albuminuria increases. So our boy presented in CKD stage 2. He was here when we saw him when he was 2 years of age, and then when he was 5 with a creatinine of baseline creatinine of 120. He was here already, so stage 4. But what is glomerular filtration rate? This is the GFR. This is the, in other words, creatinine clearance, you might hear. This is basically the volume of blood that gets cleared of a substance of the creatinine in unit time. There are, I think it's important to know this formula, 36.5 times height in centimeters divided by the plasma creatinine. You will use that not only to know what stage your patient is in, but also it's important in order to give correct dose of nephrotoxic medication like antibiotics. There are also some apps that can give you, or like online calculators that can give you the GFR as well. This is the formulary I use, the Evelina London formulary that has the doses for nephrotoxic medication for a lot of medicines. There is an app for the Evelina formulary as well, but also the link is in your educational pack that was, the link is in the program of talks, And there are also some more material to practice on calculating GFR with examples and nice guidelines on CKD as well. Please have a look if you're interested later. Let me see, there is a question. So a patient with scarring, example given post several upper UTIs, but normal eGFR of more than 90. Yes, so if there is bilateral scarring, we would still say this is chronic kidney disease. And then we would do it, the DMSA would also, as you know, give the percentages as well, which is quite helpful to discuss prognosis with parents. So going back to our patient, this is now a child with creatinine doubled, creatinine of 240. We decided we're going to give IV fluids because we need to make sure it doesn't matter if the fluids are IV or oral, as long as you hydrate your patient. We always prefer oral, as you know, enteral hydration, but we wanted to make sure that this child does get rehydrated, and he was not drinking very well because of the sore throat. So IV fluids to start with, antibiotics with the dose adjusted, and the aim in the management of AKI is to minimize kidney injury. I'm not going to go through this diagram in detail because Dr. Hayes gave a brilliant talk yesterday, and he went through that about management of AKI. But what I really want to say is that our aim treating this child would be to follow the green line and make sure his creatinine gets back to the baseline. And this would hopefully mean his CKD will develop more slowly. And here he is again, 2 years later. He's now 7, and he is now on end-stage kidney disease. So unfortunately, he had to be started on hemodialysis. So around 20 to 30% of boys with posterior urethral valves will develop CKD stage 5 during their childhood. This time he presents with 1-day history of fever. He had temperature up to 39 at home, and he has a mild cough as well. He's eating and drinking well. He's passing urine as usual. He has no dysuria to suspect a UTI. These are his observations. So no real focus on examination, but he has this mild cough. What do you think is going on? Yes, he is tachycardic. 150 is a bit high for a 7-year-old boy. He has a little bit of peripheral edema. He's a child on hemodialysis, so we don't know if that's okay for him, if it's acute or not. Yes, blood pressure is 120. Again, we don't know what his usual blood pressure, but I agree this is a high blood pressure. It means he's probably a little bit fluid overloaded. So would you admit him? Would you give antibiotics? And how much fluid? Yeah, we should do a urine dip to check for proteinuria, to make sure he doesn't have like nephrotic range proteinuria. I think this is what you mean. Dry weight, yeah, that's important to know. Put him on a fluid restriction, okay. Very good. So in terms of how much fluid, we would need to check. A lot of patients on hemodialysis, you are right, they are on a fluid restriction, so we need to follow that. We don't want him to either get dehydrated or overloaded, so we would probably follow his restriction. So he was on a 1 liter fluid restriction, so we would continue with that. Yes, I would admit as well. So it could be that he just has a viral infection, but he's quite tachycardic and he's on hemodialysis. So some considerations for patients in end-stage kidney disease. Yes, exactly, line sepsis. So whenever I get a call about a patient who is a non-patient of the hemodialysis unit, I think, when does the child need dialysis? Because dialysis cannot happen anywhere. This boy would need to come to the tertiary center to have dialysis. So it's a Tuesday. He normally has dialysis on Monday, Wednesdays, and Fridays. So he is probably all right to wait until next day. So I would probably suggest that he stays in his local hospital for the night, and then he gets transferred next day to the renal unit to have his hemodialysis. So what I need to know is that if he is safe to wait. And what I would look at is, one, his potassium, to make sure that he has a safe potassium and he doesn't need dialysis just now and he can wait until tomorrow, and at his fluid balance. I think we all agree that he's slightly fluid overloaded, although I didn't tell you the dry weight, so the weight that we aim for with hemodialysis. And his current weight, it's probably a little bit up if it's Tuesday afternoon and he's due to come next day for dialysis. His blood pressure, as long as he's asymptomatic, is not too high. He doesn't have headache. It's not very high, the blood pressure. So as long as his potassium is okay and he's not needing dialysis just now, he does not need transfer to the tertiary center for dialysis now. He can come tomorrow as long as he's stable. In terms of admitting him, he does have a central line. So some patients have a central line in situ. Some patients have a fistula. But for the patient with a central line and no clear focus of infection, you would need to treat with broad spectrum antibiotics. Talking about central lines and fistula, you can see this little lion I put here. This is an initiative from Great Ormond Street. This is a leaflet that patients with chronic kidney disease and hemodialysis are given. It's about preserving their veins. This is quite important. So even for peripheral blood sampling, antecubital fossa veins shouldn't be used because they will be needed later, maybe for fistula formation. Also, of course, if you need to take blood cultures from a central line, you would. And if you need emergency IV access and you cannot have a peripheral cannula, you would use that central line. But as much as possible, the central lines of these patients should not be used because if they lose the line, for example, because of an infection, this would mean that this line would need to be removed and then they need another line. And there is a certain number of vessels we have in our bodies. If a vessel is used, then there can be stenosis, which can cause problems for future IV access for dialysis. So we teach these patients to be very protective of their veins, to remind doctors not to take blood samples from the antecubital fossa and take the blood samples from the back of the hand, and to make sure that no one touches that central line if possible. So we talked about the usual fluid intake and urine output. There are patients on hemodialysis that are very restricted, so they might be on a fluid allowance of 500 mils per 24 hours, and they might be completely anuric. So in these patients, you need to be even more careful with your fluid balance and the IV fluids you might decide to give. But this child was not dehydrated, so I would probably not give any IV fluids, and I would just allow a little bit of oral fluids until he reaches his fluid target. Is that quite clear? Are there any questions at all? It's not very common to treat a patient like that in the DG8, but I think it's quite important to see the difference between the different types of patients who might present to you. And we talked about the signs of dehydration. We looked at this little table. So, but you also need to look for signs of fluid overload. So you need to listen for crackles, for pulmonary edema, and also don't forget the JVP. I think the more you practice checking, the better you'll become. At the moment, it's kind of, I don't know, like a dying art of the old clinicians, but it's actually really useful, especially in older children where you can actually assess. So it helps a lot in the fluid assessment. So I'm finishing with this. This boy comes again 3 years later. He's now 10 years old, and he has had a kidney transplant. Again, you won't see that often patients with kidney transplant, but I put this slide here not only to kind of close the circle of this patient's journey, but also to talk about two things. One is the creatinine. So this child has a baseline creatinine now of 50 to 55, and at this presentation his creatinine is 65. So you might think that this is a similar sort of scenario with when he presented at 2 years of age. Remember, his baseline creatinine was 50, and then it was 60 during that illness, and we thought that was not such a significant increase. But for kidney transplant patients, any increase that's more than 10% has to be taken very seriously. So this could be a sign of kidney transplant rejection. And then the fluid target. So he has a fluid target of 2.2 liters per 24 hours. You will find that patients with kidney transplant usually have a fluid target that is above their maintenance needs. So again, for this child, if you need to give fluids, it would be at least the fluid target. And on top of that, you would have to correct any dehydration. So take-home methods in terms of how to assess fluid balance and fluid status, specifically for patients with kidney disease, is history. So discuss with patients and carers the usual fluid intake and the usual urine output. This applies to general pediatric patients as well. I think it helps a lot. Don't just be reassured by a wet nappy. Just ask details. Then you need to assess the urine output, and it's quite important to keep reassessing. If you were there for the talk on nephrotic syndrome a couple of days ago, we talked a lot about how important it is to keep reassessing as patients with kidney problems, especially nephrotic syndrome. They can have quick shifts of fluid, so fluid status changes. You cannot decide to give furosemide with the fluid assessment, which was done 2 hours ago. You need to reassess your patient, and that is not just looking at the numbers of the fluid balance, but also clinically assess, feel the peripheries, decide if it's safe to give the diuretic or to go ahead with the management you have decided. And this is my last slide. So this is here just to say that I hope I've given you a little bit of a flavor of what the journey of the patients with kidney disease involves. The case we presented, everything started at 2 weeks of age when this boy was diagnosed with posterior urethral valves. And this child is going to be under the care of a renal team as a child or as an adult for the rest of his life. Kidney transplants don't last forever. These patients will go back to dialysis, and they spend a lot of time in the hospital. So during dialysis, they spend three days a week at least attached to the machine, possibly attending school at the same time. And the feeling I get is that sometimes these patients get stuck, feel like they are stuck between teams, the tertiary center and the DGH. And from my point of view, because I've recently worked in both sides, I think there is a lot we can do to help these patients to not feel like that and to feel that they are treated by the right person at the right time, close to home where possible, and feel the truth really, because it's not that the communication is not there between teams. We are one team, and we should communicate this to our families. So we have to be quite careful on how we phrase things. For example, instead of the tertiary doctor saying, I don't know about that admission in your local hospital, we can say, oh, I will call my colleague to find out a little bit more about that. The doctors in the DGH could let the patients know that we're discussing and we're managing together their admissions. This is just something to put out there, and I think it's not just relevant to the patients with kidney disease, but also to all children with chronic illness. And I think it's relevant not only to the doctors, but to nurses, dietitians, and everyone in the MDT. Let me see, there is a question. If the patient be admitted, shall we depend on weighing the type as a detector of urine output, or we have to insert catheter? I think catheter is a quite invasive procedure, especially in children. If you have a combination of daily weight, sometimes we need morning and evening weight as well. I think the weight is a very accurate way in assessing what goes in, what comes out, and then weighing the nappies as well is very helpful. There are occasions that we do need to put a catheter in, but then again, you would probably discuss with someone in the tertiary center if you were at the point that you felt you needed to put catheter in. For example, a patient who's not passing any urine and you want to be totally sure. Thank you very much. Any other questions you might have, please send them. And please do remember to send some feedback as well when you get a minute. That would be really helpful. So it's quite common regarding the polyuric patient. It's quite common to see children with posterior urethral valves to be polyuric. This is due to tubular damage, and you might see that these patients are salt, they're losing a lot of salt in their urine as well. And there is another question as well. To rule out line infection and, oh, the echo, you mean the echo to rule out line infection. I wouldn't necessarily do an echo at the first instance. I would probably just do peripheral and central blood cultures and start IV antibiotics. And then, depending on the progress, decide if that was a real line infection or not, depending on the blood cultures. Thank you, guys. I'll wait for another couple of minutes just in case any questions come up. Okay, thank you, guys. Have a good evening.